Welcome back to the Public Health Practice Gap. I am your host, Dr. Fevrier. If you have spent more than 5 minutes working in public health, health administration, community advocacy, or clinical practice, you've heard one particular word repeated like a sacred, untouchable mantra: access. We write it into our federal grants. We plaster it across 10-year strategic plans. We measure our entire professional success by it. We build clinics, we expand insurance coverage, we open resource directories, and we point to those matrices as proof that we are doing our job. We say, look, we give them access. But today, I want to start this episode with a question that was handed to me by my 5-year-old daughter. A question that completely shattered my perspective on what access actually means in the real world. About a week ago, my daughter and I were standing in a sweltering 90-degree heat at an amusement park queue under the midday sun. Now, if you've ever waited in a theme park line that long with a young child, you know that the time doesn't behave normally. It stretches, it warps. It tests the absolute limits of your parental sanity. You move 3 inches, you stop. You find yourself, you look at your watch. It has been 3 minutes, but it feels like 3 hours. As we stood there, shuffling about, a feet at a time, and our feet in the dust, my daughter was doing what she does best, relentlessly analyzing her environment. She watched our line move 3 inches in 10 minutes. Then she looked to her right. In the adjacent lane, an empty, pristine cordon-off pathway, another family simply strolled past us. They didn't shuffle. They didn't sweat. They didn't look exhausted. They bypassed the physical barrier, climbed the stairs, and boarded the roller coaster in a matter of seconds. My daughter tugged at my shirt, looked up with complete sincerity, and asked a question that stopped my public health brain in its tracks. Daddy, are we broke? Now I laughed. I knelt in the dirt and tried to explain the nuance of the situation. I told her that we weren't broke. We had simply decided to spend our day differently. I told her we had valid admission tickets and that we would still get to ride the coaster eventually. But we shuffled forward another 3 inches. A question settled deep in my brain because, without knowing a single thing about market segmentation, dynamic pricing, capitalism, or socioeconomic stratification, her 5-year-old mind recognized a fundamental structural truth. When system entry is commodified, waiting ceases to be a mere inconvenience. It becomes a penalty for a lack of resources. And as I stood in that heat, watching the fast lane patrons glide past us, I realized her question wasn't actually about our bank account. It was a profound critique of system architecture. Because today, our entire healthcare, clinical, and preventative ecosystem is run on fast lane passes. We tell ourselves that because the gates are open, the system is equitable. We scream access from the mountaintops, but the actual human cost of getting to the right is completely stratified. In this episode, we are going to tear down the semantic trap of access. Look at how we've built a clinical fast lane that leaves the most vulnerable behind, and talk about why modern public health leadership requires us to stop lecturing exhausted people in 90-minute lines and start doing the hard work of redesigning the line. Let's start by unpacking the word access. In academic and policy spaces, we define access almost entirely for physical existence of legal eligibility. We look at a map of a city. We find an under-resourced zip code, and we say, there is federally qualified health center within 3 miles of this neighborhood. Therefore, this community has access to primary care. Or we pass a policy that expands Medicaid eligibility, and we write a press release declaring that 50,000 new individuals now have access to healthcare. But this is what I called the illusion of the open gate. Going back to the amusement park, both the family in the fast lane and my daughter and I in the 90-minute queue had valid admission tickets. The park gates were wide open for both of us. The safety requirements to board the roller coaster were identical. If you audited the park's policy, you would say we had equal access to the ride. But was it equal? Of course not. One family arrived at the launch platform energized, supported, hydrated, and ready to enjoy the experience. The other family, my daughter and I, arrived at the same platform exhausted, dehydrated, mentally depleted, and clinically compromised by the heat. This is exactly how we treat health insurance or basic clinic availability in public health. We tell a low-income, single parent, you have Medicaid, you have access, but we ignore the physical, emotional, and logistical toll of actually reaching the care provider. To use that access, that parent has to navigate the invisible line of daily life. They must wait in the timeline, taking a half day off, and losing hourly wages. They must wait in the transit line, coordinating 3 different bus transfers because there is no direct route to the clinic. They must wait in the childcare bottleneck, trying to find someone to watch their other children while they sit in a waiting room. And they must pay the cognitive load tax of navigating complex, bureaucratic insurance forms written in language that requires a college degree to comprehend. When we define success by access alone, we are gaslighting the community we serve. We are telling them the gate is open, while completely ignoring that we have built an obstacle course between them and the entrance. As next generation health leaders, we have to recognize that physical access is the bare minimum. It is not the destination. Functional usability, low friction, and equitable transit are what actually determines whether a resource is utilized. If a resource exists but requires a heroic, exhausting effort to utilize, it doesn't represent access. It represents a systemic barrier wrapped in a public relation campaign. Let's look at how this plays out in the contrast between clinical treatment and preventative care. In the United States, we have built a beautifully optimized, highly lucrative clinical fast lane for those who can afford it. If you have high capital, you can purchase direct primary care. You can bypass the standard waiting list. You can text your doctor directly at 10 p.m. and get a same-day diagnostic screening. You can buy wearable sensors that track your continuous glucose levels, analyze your sleep architecture, and send real-time data to a personalized health coach. But if you are under-resourced, you are funneled into a massive, slow-moving bottleneck. If you need a routine preventative screening, you might wait 3 months for an appointment. If you experience an acute health scare, you don't call a concierge doctor. You sit for 6 hours in an overwhelmed emergency department. But it is the only place required by law to treat you regardless of your ability to pay. And here is where we commit our second great systemic error. We blame the people standing in the slow line for their own exhaustion. In public health, we have the toxic default of attempting to educate our way out of structural barriers. We stand at the back of a 90-minute queue, look at the tired, sweating people waiting in line, and hand them a brochure. We'll tell them, you need to make better lifestyle choices. You need to eat organic vegetables. You need to exercise 30 minutes a day. You need to prioritize your sleep. This is not education. This is an administrative insult. Let's look at this through the lens of behavioral economics. There is a fundamental principle of human psychology called ego depletion. Every decision we make throughout the day, resisting a craving, managing a stressful meeting, figuring out how we pay a utility bill, navigating public transit, drains our cognitive battery. If you are living in poverty or navigating systemic insecurity, your cognitive battery is completely running on empty. You are making high-stakes survival calculations every single hour. When a system requires intense, high-friction efforts just to schedule a basic screening, we are asking individuals to spend cognitive capital they simply do not have. We are asking a parent working 2 shifts who is exhausted and stressed about rent to summon the willpower to navigate high-friction healthcare system. When they fail to do so, we don't critique our system design. We critique the motivation. We write academic papers about low health literacy and non-compliance. We have to stop. We have to realize that behavior is not a reflection of moral character or education. It is a reflection of the environment. If we build high-friction pathways, only the highly resourced will survive them. If we want healthy outcomes, we must engineer healthy defaults. We are going to take a quick break, but when we come back, we are going to look at the economic reality of this fast lane model, why the commercial interests that own the park are actually incentivized to keep the main line slow, and how we can structurally break that loop. But before we do so, let's talk about building those default systems in your own community. If you are listening to this and realizing that your organization is still building empty rides, designing complex, high-friction programs, and wondering why your community engagement is stalling, I built the Next-Gen Public Health Lab specifically for you. Every Wednesday, I publish the Next-Gen Public Health Brief newsletter. It is completely free, and it is designed to deliver systems-level critique of healthcare directly to your inbox. You can subscribe right now at the nextgenpublichealthbrief.substack.com. But if you want to move past high-level theories and access the actual field manuals, diagnostic toolkits, and slide decks my team and I use to design healthy default environments, I want to invite you to upgrade to our paid publication, the Lab Notebook on Substack. Your paid subscription directly funds independent, conflict-free, translational research and gives you direct access to our collaborative roundtables and system audit sheets. And finally, if your health system, nonprofit, or governmental agency is ready to stop trying to change minds and start changing the physical and systemic defaults of the environments you serve, let's partner directly. From strategic consulting and choice architecture audits to leadership development, we help health leaders close the implementation gap. Visit nextgenpublichealthconsultancy.com to schedule a consultation. Let's stop lecturing. Let's start designing. Now, let's get back to the show. If you are just joining us, we have been deconstructing the illusion of access and exploring why clinical fast lanes and preventive bottlenecks are actively stalling our community health matrices. Now let's look at this through the lens of cold, hard economics. We have to ask a blunt question that most public health conferences and academic papers carefully dance around. Who actually benefits from the wait? Let's go back to the amusement park one last time. If you look at the park's financial spreadsheets, you quickly realize that the park owners don't just tolerate long lines. They are actively incentivized to keep them. Think about the math of the fast lane business model. If the regular queue for the roller coaster moves in 5 minutes, if the ride operators were lightning fast, or if the pathways was perfectly optimized, why on earth would any guest pay an extra $150 for a fast lane pass? They wouldn't. The pass only has commercial value because the standard line is an agonizing, sweltering 90-minute penalty. In economic terms, the profitability of the premium bypass is directly proportional to the dysfunction of the baseline queue. Once you see this loop in a system design, you cannot unsee it in the modern American healthcare. We are trapped in a systemic cycle where clinical scarcity and preventive dysfunction are highly lucrative. We operate inside a fee-for-service sick care economy. Under this system, hospital networks, specialty clinics, and pharmaceutical companies do not make money when communities are healthy, active, and thriving. They make money when patients are sick, in crisis, and funnel into high-cost, high-tech diagnostic and specialty rides. It is incredibly profitable to sell a $1,000 a month weight loss injection to manage obesity downstream. It is highly unprofitable under our current economic model to design a workable neighborhood with community support agriculture, integrated pedestrian walkways, and structural food security. One model is a clinical fast lane pass sold to individuals who can afford the capital or the insurance approvals. The other model is fixing the main line for the entire community. When we allow healthcare to be designed as an individual consumer product rather than a collective public good, the wealthy and the highly resourced buy their way out of the broken lines. They get concierge doctors, continuous glucose monitors, and private wellness suites. And because the most influential, politically active, and wealthy segments of society have successfully bypassed the line, the pressure on the system planners to fix the baseline queue completely evaporates. Why repair the tracks of public health when the people who fund the system can just buy a bypass? As next generation health leaders, we have to recognize that we cannot scale individual bypasses to 100% of a population. If we try to solve a systemic queue problem by selling more bypasses, we don't solve the wait. We just make the line longer and more expensive for the people at the very back. So how do we structurally break this loop and redesign the line? We do it by executing what my team and I call a behavioral friction audit. Remember, our systems thinking equation from earlier. The probability of an individual executing a healthy behavior is inversely proportional to the cognitive and physical friction of that choice. If we want to change behavior, we must ruthlessly minimize the cognitive load. To run a behavioral friction audit, you must put down your academic brochures, step out of your administrative office, and physically walk the user journey of the most vulnerable person in your target demographic. Let's say you want to increase the rate of childhood immunization in an under-resourced zip code. Step 1 is to locate the friction points. Do not just look at whether the clinic has vaccine doses in the fridge. Walk the line. How does a single working parent schedule the appointment? Do they have to call during working hours and sit on hold for 20 minutes? Eliminate that. Shift to the text message scheduling with automated single-click confirmations. Step 2 is to look at the physical transit. How does the parent go to the clinic? If they have to take 3 buses, you have built a high-friction line. Redesign it. Take the vaccine out of the centralized clinic and move it to the trusted, default environment where families already gather. Local schools, neighborhood community centers, or faith-based health partnerships on Sunday mornings. Step 3 is to evaluate the intake bureaucracy. Does the parent have to fill out a 12-page clinical registration form written in dense academic legal terminology while wrangling a screaming toddler? That is a cognitive load tax. Simplify it. Design one-page intuitive intake forms or use peer navigators to fill out the paperwork for them while they wait. By systematically auditing and removing these micro-frictions, you change the default choice. In behavioral economics, we know that human beings do not choose what is best for them in a vacuum. We choose the path of least resistance. If you make the healthy choice the easiest, low-friction default option, population behavior will shift overnight. We don't need to change people's minds. We need to change their defaults. As we wrap up today's episode, I want to bring you back to the exit ramp of the roller coaster. Eventually, my daughter and I reached the front of the sweltering line. We climbed the platform, buckled into our seats, and for about 90 seconds, as we zoomed through the loops and drops, she laughed, screamed, and had the absolute time of her life. As we walked down the exit ramp, she had completely forgotten about the 90 minutes we spent sweating in the dirt. Her mind was entirely filled with the joy of the ride. But as a father and as a public health practitioner, I could not forget, because the ride may have been identical for everyone, but the human cost paid to reach it was completely unequal. And that is the core challenge of modern healthcare and public health. We cannot continue to pat ourselves on the back for building state-of-the-art clinical rides while leaving the vast majority of our communities to sweat, deplete, and collapse in the lines we've built to reach them. The next time you are analyzing a strategic plan, reviewing a grant proposal, or designing a clinical intervention, I want you to look past the admission gates of basic access. I want you to ask the uncomfortable question: is this system actually designed for this community to succeed? Because if the default path we build requires heroic, high-friction efforts just to survive, the real story isn't the clinical outcome. The real story is the line. And our job, as the next generation of public health leaders, is to stop lecturing the exhausted people standing in it and start doing the heavy, structural work of redesigning the line. If this episode challenged your thinking, please take 30 seconds to leave us a 5-star review on Spotify or Apple Podcasts. Share this episode with a colleague on LinkedIn, and make sure you subscribe to the Next Gen Public Health Brief newsletter. You can join thousands of other industry leaders by signing up right now at the Next Gen Public Health Brief on Substack. Finally, if your health system, nonprofit, or governmental agency is ready to stop printing pamphlets and start changing the physical and systemic defaults of the environment you serve, partner with us directly. Visit nextgenpublichealthconsultancy.com to schedule a consultation. Let's stop lecturing. Let's start designing. I'll see you next Tuesday. Let's get to work.